Good morning to respected MCh Resident, Dr. MCh Resident, sir, and all my respected teachers and colleagues. And thanks for giving this time opportunity to our department to present CCR. In brief, I am introducing my department to all of you. And we established department in 2012 with interesting story. I met with Dr. Vikas Shankar for the joining of this institute with Dr. Sudhi Sachdev. I requested so many things, dialysis machines and other things. Dr. Sachdev told me, आप तो बहुत कुछ मांग रहे हैं, बहुत सारा इधर सारा काम ताम इकट्ठा करके और फिर कहीं भाग जाएंगे, लीबिया वगैरह कहीं चले जाएंगे. तो आई डिड माई कमिटमेंट कि मैं कहीं इंडिया छोड़ के कहीं नहीं भागूंगा, यहाँ पे ही इसका और अच्छे से विस्तार करेंगे. So now we are having largest unit in the dialysis unit in the state with 45 plus dialysis machines. And 4 more machines are coming in next week. So almost we will have 50 machines. And we are having state-of-art all variety of machines like slate dialysis machines, CRRT machines, advanced plasma access machines. And we are doing around 2,800 to 3,000 dialysis per month. In spite of we are doing 30 plus transplant per month. So 30% are converting into transplant. So they are minus in the dialysis pool. And we are having one of the few centers in the India which is doing all kind of international nephrology. We are doing AV fistula or department itself, and we are doing USG guided and fluoroscopy guided hemodialysis catheter insertion, USG guided renal biopsy, both native and graft biopsy, and we are also having DM program with 4 seats. We started in the renal transplant. We got the first time permission in November 2012. We started the 2 transplant in 12, and then this graph is showing that increasing year by year. We did almost 185 in the 2019. There is a dip in COVID time in 2020 due to lockdown and other so many things. So still we created our SOP of our institute, and we managed to did around 121 the 2020, and in 2021 at the time of COVID also we did the 238 transplant. In the 22 we completed more than 300 transplant, and in last year we did 402 transplant in the 2023. Till in 24 we did around 100 transplant till 30th March. All transplant we did the always kept institute on priority. We did all transplant in the legal framework. We did and we are doing, and always we will do in the legal framework of the country. Some of the milestone we created in the state as well in the nation. We did the first SWAP ABU incompatible transplant in 2016. So far we did the 190 ABU incompatible. Is there few centers in India which is doing so much ABU incompatible transplant. It's a very complex surgery as well as immunology. We did the first SWAP transplant in 2014 of the state as well as the few in the nations. So far we did around 125, and we did the first disease donor of the state in 2015. So far we did the 21 in the so far, but in this field we are lacking, so we are trying to increase these numbers. We did the first combined liver kidney transplant, as we did the first pancreas kidney transplant of the state. Now I would like to invite Dr. Aviral to present for this year.
Good morning, everyone. Respected sir, faculty, my colleagues and my juniors. I'm Aviral from Department of Nephrology. I'll be talking to you about a unique case. We'll follow the journey of this case from the time she had presented to us to the time we got her to her final destination. So let us talk about her when she had presented to us. She came to us in March of 2022. She's a 46-year-old female. She came with history of swelling of feet on off for the last 2 to 3 years, which was increasing. It was associated with a generalized weakness. She gave to us no significant prior medical or significant familial history. She has 2 children, both are living, no abortions, and she gives otherwise unremarkable obstetric and menstrual history. At this point, she is evaluated and she's found to be hypertensive with a BP of 102/108. So her basic lab workup is done at this stage. The creatinine is done. The creatinine is 4.8. So we must understand that any patient who has come to with a stable creatinine, we must always do the GFR. The GFR is the true reflector rather than the creatinine itself, which is influenced by many other factors. So here, if you see, the GFR comes to around 11 mmol per minute. So then going ahead, the other investigations are showing a hyponatremia, slight hyperkalemia, low bicarbonate, low calcium, low albumin, high phosphorus, and high PTH. So at this point, she is found to be anemic. Her hemoglobin was 7.2. The MCV and MCH were done, which are in the normal range. A peripheral blood film was done, which is showing a normocytic normochromic anemia. As she had renal dysfunction, urine routine is also done at this stage, which was showing 2+ proteinuria and 16 to 18 RBCs per high power field. So in this case, we know that it's a renal dysfunction. So what we are at this stage thinking, is it an acute kidney injury or is it a chronic kidney disease? And if it is, whatever it is, a AKI or a CKD, we are thinking, what is the etiology behind this disease? So further investigations are done at this stage. So we do get a fundus examination done. It is showing to us grade 1 hypertension retinopathy. This indicates that there is some component of chronicity to the illness. An ultrasound of the KUB is done. It shows us a decreased kidney size with a poor corticomedullary differentiation. There is no other obstruction or calculus that could be visualized. Echocardiography is done at this stage, which shows a concentric LV hypertrophy, again suggestive of a long-standing hypertension. The ejection fraction is found to be normal. At this stage, we do a ANA by immunofluorescence and an ANCA study. Both were negative. Now, at this stage, ideally, we know we have a renal dysfunction. We know we have proteinuria. We would like to get a renal biopsy done at this stage. That is the gold standard to establish a histopathological diagnosis. Unfortunately, in this patient, if you have noticed, first of all, we have a decreased kidney size. So when we have a decreased kidney size, biopsy is technically difficult. We are more likely to run into complications. And in addition, as the disease is already advanced, we are more likely to only get glomerulosclerosis. And the main thing in the biopsy that we are going to require is the immunofluorescence. So a kidney which looks like this on the ultrasound is going to have a burnt out disease. We may not find anything on the immunofluorescence. So in this case, we decided not to go for the biopsy. So now at this stage, we have enough data to form a diagnosis. Can anyone contribute what is the likely diagnosis in this case? Final diagnosis. So at this stage, we form a diagnosis. She's a 46-year-old female with clearly chronic kidney disease, stage 5. If you remember, her GFR was 11. With CKD, MBD, mineral bone. So by itself, a GFR of less than 60 for 3 months is going to be labeled as chronic kidney disease. 60 ml per minute per meter square, 1.17 meter square. Yes. And she's having mineral bone disease. She's having anemia of chronic disease and hypertension with a grade 1 retinopathy. So now we start her on the treatment. We start our medical management that we give to most of our chronic kidney disease patients. We start her on diuretics, antihypertensives, sodium bicarbonate, calcium and vitamin D supplementation, phosphate binding agents. We give her IV ferric carboxyl maltose and discharge her on erythropoietin 4,000 units subcutaneous twice weekly. So these were her trends. So our story starts in March of 2022. These were the trends. If you can see, the creatinine from 4.8 slightly raised to 5.1. And in August, on the last follow-up, it was 5.6. She did not follow up with us for the next 4 months, but she ended up to us in December of 2022. She came in the emergency. At this point, she's having breathlessness, which is NYHA grade 4. And she's also having edema despite being on a high dose of diuretic. She has a poor appetite. At this point, she's admitted for inpatient evaluation. As you can see, her creatinine was found to be very high. The urea was 220. Potassium is also on the higher side and hemoglobin was low. So at this point, we decide, in view of edema, very deteriorating renal function, hyperkalemia, we start to initiate her on hemodialysis with right internal jugular vein, non-tunnel hemodialysis catheter. At this point, one packed red blood cell was transfused to her. Then after she improved at this point, we dialyzed her 3 to 4 times inpatient, and then she was advised to stay on twice weekly dialysis, and then we discussed the option of undergoing renal transplantation with her. At this point, the family was undecided, and so we gave them a schedule for twice weekly maintenance hemodialysis, and then we went to create, because she's presently going to be on dialysis, we went to plan the long-term vascular access. So as we are all aware, the best long-term vascular access for hemodialysis would be AV fistula. So that's what we attempted. If you see, first whenever we are going to make AV fistula, we always go for the non-dominant hand, preferably with the distal followed by the proximal vessels, because there is more segment to cannulate. So in her case, we went and made a radiocephalic fistula. However, it thrombosed within the first weeks after making it, and it was never functional. Then we went ahead, there was one more suitable site, so we went ahead and made a left brachiocephalic AV fistula. However, that also failed to function. There was a primary failure of the fistulas. So at this point, we just had to continue dialysis through the IJV, because the contralateral limb also did not have any suitable vessels for creation of AV fistula. So the issue arises that her IJVs also keep getting thrombosed. We had put 4 times IJV in her, in both right and the left side. So both sides were clotted within 2 to 3 weeks of the IJV, which is very, very unusual for us. So at this point, we are forced to go for a femoral access, as she has no other functional access for hemodialysis. So left femoral tunnel dialysis catheter is placed at this point, and she continues to have dialysis through that catheter. So now at this point, I would like to invite suggestions from the audience. In such a patient of CKD who is coming to us with such significant access thrombosis issues, what should be the evaluation? What would be the common etiologies that can contribute to this? Okay, applies one differential. CKD by itself is a prothrombotic state, but this is very unusual even for a CKD. This is too much thrombosis for CKD. APLA is a common differential. All other thrombophilias would be our differentials. If it was in just one single axis, we could also very significantly think of there being issues with that axis itself. But this was not the case, because this is happening at multiple sites in different segments of the body. So at this time, we are also thinking of a thrombophilia. So we sent a thrombophilia workup. If you pay attention, most of the tests are negative, but the first differential is correct in this case. We find her to be positive for anticardiolipin antibody, both IgG and IgM, and her lupus anticoagulant is also positive. So at this point, judging by her history and with the unusual case of thrombosis, we diagnose her as having APLA syndrome. We start her on warfarin as she already has a case of thrombosis. She's indicated for both anticoagulation as well as aspirin. So we start her on both. The titer for INR in this case would be between 2 and 3, which is what we kept. So she is now on anticoagulation, and the access is functioning for now. For the next few months, the access is working, the left femoral tunnel dialysis catheter. So then around 1 month from the starting dialysis, she came to us with a fever of low grade with evening rise and loss of appetite. There was no other obvious pointers. All the immediate causes were ruled out. On examination, we happened to find a left-sided palpable lymph node. She underwent a biopsy of that lymph node, which was suggestive of a tuberculous lymphadenitis. So we started her on the standard 4-drug ATT modified to the renal function. So as we can see, this is a very frequent issue with us, which drug should be given in chronic kidney disease patients. What we need to understand, that main drug that is going to require modification is ethambutol. So you can either give a half dose of what you would give in a usual patient, you can dose it OD, or you can give the full dose thrice weekly. That is the main modification that is going to be required. But it is very important we always check it according to the GFR. So at this point, she is a patient of CKD on dialysis, significant access issues. She is on a catheter that we don't really want to keep. It is the worst possible options. We discuss with the family at this that she's very unlikely to maintain a long-term functional vascular access. So at this point, they discuss among themselves, they come back to us, and now they want to undergo a renal transplant. So we see her options. At this point, the only potential donor in the family is the husband. So we get the blood groups done. The patient's blood group is AB positive, we already know.
Yes.
So her husband's blood group is found to be B positive. The patient is AB positive, she's a universal recipient, so there is no issues at this point. So we get the transplant workup started with donor as the potential husband. potential donor as the husband. Then we get the transplant evaluation done. So we got all the basic workup done, all the medical fitness from the different departments, cardiology, psychiatry. We get the PAC done. So when we complete all the medical workup required, then we are going to go for the immunological workup. Her medical workup was found to be unremarkable. Both were fit. So then we go for a flow cross match. So that is our trend. So first step would be, after completing the medical workup, we'll go for a immunological workup, flow cross match and HLA match. So in her case, we sent a flow cross match. The flow cross match is positive for both T and B cells. So we will see how we'll do the further workup in this case. So if you see to the left side, so this is what we do. What does the flow cross match mean? If my flow cross match with my donor is positive, that means most likely I am harboring some antibody against that donor. So what would we like to see next? We would like to see that antibody. That is what the test called single antigen bead is. We are going to see all the antibodies which are directed against HLAs. So in this case, if you see she is a HLA class 2 positive, the antibodies specificities against the HLA loci DRB13 and DRB14. So then we would like to know, so we have some antibodies against HLA. We would like to know if the donor is actually having those HLAs. So this is the donor's HLA on the right, her husband. If you see that he does have the DRB13 locus on his HLA, so now this becomes a donor-specific antibody. Donor-specific antibody, if the patient is already harboring a donor-specific antibody, we cannot go ahead with this transplant. This kidney is likely to get acute rejection. So now we are stuck. How do we move forward? What are the options left for her? First option, transplant with husband as donor. As we discussed, it's not feasible. There is very high risk of rejection. We go ahead, she is on dialysis, so most of these patients, we can simply keep them on dialysis. But in this particular case, there is a peculiar and very unique pathology. It will be very difficult for us to maintain her on hemodialysis because there will be no long-term functional vascular access. So at this stage, we did enlist her for deceased donor transplant. And at this point, she's not doing well. The access is a big issue with her. There's an issue to get her dialyzed, and we are worried that if this access gets thrombosed, we will not be left with any other access also. So at this point, we gave them the option to go for a kidney pair donation. So how we go about doing a kidney pair donation is, we have a registry of some 30 to 40 patients. These are all the easier to match donor recipients. We are going to swap them within the first few months, but we have a registry of around 30 to 40 patients. Those who have significant HLA antibodies, who are caused hard to match recipients. So we keep all their records, and whenever a new patient is going to come to us, we're going to enroll them in the registry, and then we are going to match their records to see if the suitable donor can be found. So at this point, we could not find a direct donor recipient pair that could exchange with her. So we are also at the same time having many such patients whom we cannot transplant because of significant HLA incompatibility. So at this point, we see all the records and we have an idea how about we go on making a chain. So we try to find 4 or 5 patients which we can accommodate later. And this case, luckily for her, as this patient we were treating on a priority basis because she simply cannot stay on dialysis for long. So we found 5 other such pairs that could possibly be suitable with her. So at this point, we see that all those pairs have also undergone the workup. The medical workup is completed. We have HLA records and the single antigen like we saw previously. We have these records for all these pairs. And at this point, how we go about doing the matching is, for example, I am a recipient. I have my single antigen bead. We know what antibodies are present in my body. So I'm going to get the potential donor's HLA. I'm just going to match it. So if there is no antibody against that HLA, that means it's a negative virtual cross match, which needs to be confirmed by a physical cross match. So at this point, we make a tentative swap chain. And it is very important from legal point of view and from ethical point of view in India that all the patients who are undergoing swap transplantation, they must meet each other. We have to maintain complete transparency regarding each other's report. So it should not be like, humko kharab donor de diya. They must be aware of all the reports with every other pair. So at this point, all the pairs are good to go, and we went ahead and set the physical cross match in the laboratory. This is the basic workup sheet that we do, all the investigations. So now we have a potential chain in mind. So the table may look daunting, but we just have to focus on the blood groups. So if you see first recipient, so if you see the donor in this family, the donor is O. So O can give to B, the patient himself is B, but O can give to B. Issue is the flow cross match is positive. Again, like similar to our index case. Now the index case that we discussed is R4. If you see in her family, she is AB. The husband is B. B can give to AB, but unfortunately in her case also the flow cross match is positive. Similarly, there are 4 more pairs with various etiologies. In all 4 of them that are left, there is the incompatibility is AB rather than HLA. So now we have 6 pairs who are possibly compatible with each other, although they were incompatible with their own donors. So if you see, what is very significant to notice in this, if you see these arrows, we are only taking potential donor to recipients as ABO compatible. It is very important that we don't go for ABO incompatible in this chain. So all, if you see B to B, A to A, is all the same compatible blood groups are being given. At this stage, now we say go for a physical cross match. We are expecting them to be negative, but we send them to the immunology lab. These were the donors, all were healthy donors with no significant issues, and all the GFRs were above 90, quite acceptable. Now, I would like to invite Dr. Shweta Sharma from Department of IHBT to discuss more about the pre-transplant immunological workup.
Thank you, Dr. Aviral. A very good morning to all the respected faculties and my dear colleagues. So today I will be discussing few things about the case. So algorithm is something which we really need to follow before going for the transplant, as we cannot rely on a single test before going for the transplant. So we have to have the battery of the test to decide which test is complementary to the another one, and after deciding all the tests, after deciding all the results of the test, we can proceed whether we have to go for the transplant, or we have to desensitize the patient, or we have just no for the transplant. So the main test for the renal transplant are to find out the ABO compatibility or the incompatibility, HLA typing, testing for the anti-HLA antibodies in the recipient serum, and to detect the DSA, that is the donor specific antibodies. Along with that, we do the flow cross match, that includes CDC cross match and the flow cross match. As we all know that they are the main basic 4 blood group systems. One is group A, B, AB and O. As we know that there is no antigens present in the group O, and in group AB we have both the antigens, antigen A and antigen B. For the group B we have B antigens, and similarly for the group we have A antigens, and group O we have both the antibodies in patients with the group O. Whenever we are going for the ABO incompatible transplants, then this is the major criteria. So major, manner and the bidirectional. In the major, the recipient can be O, A and B. For the manner, it can be A, B and AB. For the bidirectional, it can be A and B. For the donors, for the major, it will be, for the O, it will be A, B and AB. When the recipient is A in the major, the donor will be of AB blood group, and for the B, the donor will be of AB blood group. Similarly, for the minor matches, when the recipient is of A, then the donor should be of the O group. For the B, the donor should be of O. For the AB recipients, the donor should be of O, A and B. For the bidirectional, it's A for B and B for A. But now the question arises that if we go for the ABO incompatible transplants, then what we have to do? We have to go for the titrations of the antibodies. And for the titrations, what is recommended? To go for the plasmapheresis, and the baseline titration should be 1:8 before getting enrolled in the transplant program. As per the government guidelines, we are following all the norms. This is our requisition form which has been designed based on the government guidelines. We never receive any form which has not fixed with the photographs of the donors and the patients which have been planned for the transplant. And on the forms, it's mandatory to have the stamp of the treating doctor. These are the government guidelines which we are following for all the transplant cases. Even the forms are not accepted. Like, we accept the forms and we collect the samples directly in our transplant immunology lab only. Talking about the HLA, these are the cell surface molecules found on all the nucleated cells. Each individual has a unique set of these antigens, half inherited from the each patient. Now, it is located on the short arm of chromosome 6 and it consists of HLA class 1 and class 2. Both are very, very highly polymorphic. Class 1 is for A, B, C and class 2 is for DP, DQ and DR. HLA typing is mostly required when we want to establish the relationship and when we want to know how much match is with the patient or with the donor. But not only this, HLA is very much required for few diseases like HLA B27 is positive when it's a rheumatoid arthritis. It is positive, B40 is positive for the cases of the leprosy. Our institute is fortunate enough to perform all these tests under the one roof. The major tests for the renal transplants are divided into three categories: HLA typing, cross matches, and the virtual cross matches. HLA typing is of two types: low resolution with the help of the Luminex and the high resolution with the help of the NGS. In the low resolution typing, it is not more precise. But the high resolution typing is more precise. It helps to detect a single antigen for the allele. Cross matches are of three types, that is CDC, Luminex and the flow cross match, whereas the virtual cross match is SAP, that is we call as single antigen bead assay. Recently we got the NABL accreditation for the NGS typing in our institute. Talking about the HLA typing, in this donor antigens expressed on the surface of the leukocytes or genes are matched with the recipients. Closer the HLA match, lesser the chances of the rejection. That means if there is 3/6, that means they have a haploidentical. If it's less than 3, then it's not recommended to go for the transplantation. We are having these two machines in our department. The first one is NGS, that is based on the high resolution. The another one is the Luminex, which is based on the low resolution. Talking about the CDC cross match, in this we take the patient serum along with the donor lymphocytes and the complement. If there is no DSAs found, then there will be no lysis and it will be negative. But when there are DSAs, it will bind to the lymphocytes and it will activate the complement system, resulting into the positive test. The flow cross match, it is similar, but in this we add some fluorescent label antibodies against the human IgG, and if again the no DSAs are there, the test will be negative, and if DSA is there, the test will be positive. But this test requires flow cytometer machines. The major difference between the CDC cross match and flow cross match is that the CDC cross match is a very old one, but nowadays the doctors are preferring this flow cross match. CDC cross match is more times it comes false negative when the titer value is very less, and it is more time consuming, and thirdly the result is variable. It is inter-observer result variations are there. Now, what are the donor-specific antibodies? DSA are the antibodies in the recipient serum which are specific to the donor, and these in high titer are an absolute contraindication to the patient. After transplantation, patient may develop the de novo DSAs, so they need to be follow-up after the transplantation. Many patients have pre-formed antibodies. Common sensitization events include pregnancy, the patients having the history of multiple blood transfusions, and any history of the previous transplant. So we received samples from 6 different recipients and 6 different donors. Their blood groups have already been discussed. After doing the flow cross match, in the case 1, it was positive for the T and the B cell, and the SAP test was advised. Similarly was the seen with the case 4. The T and B cells were positive and the SAP was advised. The rest of the 4 cases were ABU incompatible, but their flow crosses were negative for T and B cells. Now I would like to invite Dr. Aviral to please start.
Sir, the plasmapheresis done, so depends on the titer. So what we expect, the titer is always in multiples of 2. So what the most common decrease of the titer is, we typically will have patient with, let's say for example, 1:256 or 1:512. So in most cases the titer halves when we do one single session of plasmapheresis. But in many patients, it could be that the titer might even drop by 2 times or 4 times or even 8 times occasionally. So our approach is, for example, if it's 256, we would typically need 3 to 4 is our usual average. So if we are doing at 256, we would require 4 cycles of plasmapheresis to reach at the titer of 1:8. However, the recommendation, if the titers are above 512, can do, but the risk is very high in those titers, and it will not be possible in many of these patients. So at that time, we might need to abandon the ABO incompatible and look for another donor. So let us come back to our payers. So we had sent all the cross matches to the IHBT department. So we already had a negative virtual cross match. So we expect, like, most likely these patients are going to be compatible with each other. So fortunately for us, all the 6 flow cross matches came to be negative. So going back to our index case. So if you saw at that point, her flow cross was positive. With the donor she had in her family, it was positive for both T and B cells. If you see at a new cross match, we have assigned her a new donor designated D5. Her cross match is negative. So this transplantation we can proceed with. So at this point, we already had the pre-transplant fitness. It is very important that before even enrolling them in the kidney paired donation, both of them should be physically fit. So they were already fit. Now we have immunological compatibility established. So at this point comes the most significant stage of completing the legal formality. So our role as a transplant center in this is we are just going to give them a list. For example, whatever the relation might be, marriage certificate or birth certificate or HLA reports is required if they are blood relatives. We will forward the patients to the state authorization committee. The state authorization committee considers all this report, and the state authorization committee is going to generate the NOC and give it to the patient party. Then the patients will get the NOC to us. Only after we get the NOC from these patients, then we will work them up for transplant. It's very important. In this case, as they were all kidney paired donation, so for all kidney paired donation, that the committee can only be done at a state level. It has to go to the state authorization committee, and we have no role in that. So we have the NOCs. The files were reviewed at this stage, and whatever, if there is any repeat investigation to be done, we got it done, and then we have a date in mind where we can do this transplant. So this is what the chain looked like. So if you see, the compatibilities are listed. So we have already discussed this, but this is what, so we have eliminated the names here. This is what we had printed at that point, and it was there with us for in the preceding few weeks before doing the transplantations. So now going to the preoperative preparation. So all the patients were admitted at 2 days prior to the transplant. At that point, we started the standard immunosuppression, which is tacrolimus and mycophenolate mofetil. We did the routine pre-op investigations, electrolytes, PTA, PDT, CBC, etc. All the patients were already on dialysis with variable dialysis duration. So we dialyzed them, all of them, 1 day prior to the surgery. We got a review pre-anesthetic checkup terms once we had the investigations. On all patients and donors were found to be fit at the stage. So then going ahead, on the day of the surgery, all our preparation is done. So in the morning, we shifted the patients out to the operation theatre 1 by 1. And they were handed over to the surgical anesthesia teams. So now we had to decide about the induction. So 5 of the recipients, we had given anti-thymocyte globulin. We gave a dose of around 1 to 1.5 milligram per kg intra-op with injection methylprednisolone. And we completed the total dose of 3 mg per kg in the next 3 to 4 days. And one of the recipients was given injection basiliximab Simulect 20 mg, which is a IL-2 receptor antagonist antibody, at day 0 and 4 with a methylprednisolone 250 mg. This particular patient was post CABG and had a poor ejection fraction at 35%. So now I would like to invite Dr. Suma from Department of Organ Transplant Anesthesia for the anesthesia perspective.
Good morning, everyone. And I'll be talking about perioperative anesthesia considerations, preoperative, intraoperative, and postoperative challenges. So preoperative optimization in these patients is quite challenging because all the patients with ESRD have multi-system involvement, like cardiovascular system involvement in the form of coronary artery disease, dilated cardiomyopathy, uremic cardiomyopathy, pericardial effusion, and respiratory system involvement in the form of bilateral pleural effusion, pulmonary edema because of fluid overload, and CNS involvement in the form of uremic encephalopathy. And apart from this, all these patients had anemia, platelet dysfunction, and coagulation abnormalities, and all these things has to be optimized prior to the surgery. And maintaining optimal perioperative fluid balance is very important because giving excessive fluid in the intraoperative period has the risk of pulmonary edema and congestive heart failure in the patients, and which may require postoperative mechanical ventilation, and also the risk of graft congestion and increased risk of intraoperative bleeding because of dilution of coagulation factors. And on the other hand, if we give less fluid in the intraoperative period, there may be a risk of delayed graft function, AKI, and acute tubular necrosis. Coming to hemodynamic stability, the main aim is to maintain optimal perfusion pressure by maintaining mean arterial pressure around 90 to 110 millimeters of mercury, so for the better graft outcomes. So intraoperatively, hypotension and hypertension has been managed with titrated dose of norepinephrine and NTG respectively. And all these patients also have some electrolyte abnormalities like hypercalcemia, hypocalcemia, hyperkalemia, hyperphosphatemia, and acid-base disturbances like metabolic acidosis. And all these things have to be corrected prior to the surgery. And adequate pain management in the form of facial plane blocks like transverse abdominis plane block, erector spinae block, quadratus lumborum block, and intrathecal morphine has been given to mitigate the side effects associated with the pain and also to enhance the post-operative recovery. So, coming to pre-operative challenges, 1 day prior to the surgery, all donors and recipients were thoroughly evaluated in terms of medical and surgical history, and all donors belonged to ASA grade 1. All of them were healthy normal subjects without any comorbidities, and all recipients belonged to ASA grade 3, and all the recipients are CKD patients who are undergoing regular dialysis. And among 6 recipients, 4 of them were hypertensive who were on antihypertensive medications, and one of the patient is both hypertensive and type 2 diabetic, and he also underwent coronary artery bypass grafting in the year 2022, and he had an ejection fraction of 35%. And one patient, this is the index case, this patient is both hypertensive and a known case of hypothyroidism and a known case of antiphospholipid antibody syndrome. So in the index case with Apler syndrome, she was on, the patient was on warfarin and aspirin, and she also had a low platelet count. So warfarin has been stopped 5 days prior to the surgery, and aspirin was continued in the perioperative period. Bridging therapy started with unfractionated heparin, which was stopped night prior to the surgery and restarted on the postoperative day 1. So in the same patient, we have sent a sample for thromboelastography, which came out to be normal in the perioperative period. So as 12 interconnected surgeries were planned on a single day, to avoid any mishaps and misidentification, proper tagging of the patient has been done, both donors and recipients, in the form of wristbands. So donors with wristbands has their respective details and the details of the recipient, and the recipient wristbands have their respective details and the details of the donors. And final list establishing this donor-recipient pairs were put up in all OT operation theatres. So, and on the day of surgery, and all the recipients, apart from the standard anesthesia monitors like ECG, NIPP, SpO2, arterial line cannulation has been done on the non-AV fistula side. So for invasive blood pressure monitoring, for serial ABG sampling, and also for recording the pulse pressure variation to direct the intraoperative fluids. And central venous cannulation has been done for giving the induction agents, inotropes, and vasopressors. And in one recipient who has underwent the CABG and who has this low ejection fraction, we have connected the flow track monitor. And this flow track monitor is an advanced hemodynamic monitoring system, so with which we can monitor the preload contractility after load in terms of stroke volume, systemic systemic vascular resistance, cardiac output, etc. And this hemodynamic monitoring system has been continued in the postoperative period also. Out of 2 recipients, R4 and R6, they have low platelet count in the preoperative period. So to assess the bleeding risk and also to arrange for the blood products, we have sent a sample for thromboelastography in the preoperative period, which came out to be normal. And in one recipient, that is an R6, because of intraoperative bleeding, we have again sent the sample for thromboelastography and we have given the blood products accordingly. All grafts were functional immediately after the reperfusion with good urine output, and all the patients were extubated on the OT table on the day of surgery and shifted to kidney transplant unit. Postoperatively, the recipient R2 had an episode of paroxysmal supraventricular tachycardia, which has been reverted to normal sinus rhythm with carotid massage without any need of pharmacological intervention. And patient was stable afterwards. And rest of the donors and recipients had uneventful postoperative recovery. So post-operative pain control has been individualized to ensure adequate post-operative analgesia and also to mitigate the side effects associated with pain in the post-operative period. So now I would like to call upon Dr. Kishan from the Department of Urology to discuss about surgical act.
Good morning, everyone. Thank you, Dr. Suma. So moving forward, as you know, all the donor nephrectomies were done laparoscopically, and out of 6, 5 were left-sided nephrectomies, and 1 we have to take the right side donor kidney to overcome the short length of renal vein, and there were 3 accessory renal arteries on the left side, so we decided to take right kidney. And we prefer left-sided donor kidneys as we have long length of renal vein. And as you know, the external iliac vein in recipient bed is deeply seated, so we prefer left-sided kidneys in majority of cases. So we started the first case early morning, and all the donor nephrectomies were uneventful, and all the donors were discharged on day 5 as per routine. So after receiving the kidney, it is meticulously prepared. All the extra fat and adipose tissue is ligated, and surrounding extra vessels are clamped, and graft is now ready to be placed. I would like to ask a question. Can anyone tell whether the donor kidney is placed in recipient? Any student? What place? Yes, sir. So it is an heterotopic transplant. It is not orthotopic, as we don't need to do native nephrectomy. So recipient kidneys are left as it is. In majority of cases, we don't need to remove it. So this is the benching. The donor kidney is prepared. Extra fat and tissues are removed, and the kidney is perfused with electrolyte-rich solution. And once it is ready, it is ready to be implanted. So this is the retroperitoneal space which we create in a majority of cases in right iliac fossa. So this is the retroperitoneal bed. As you can see, the external iliac vein is exposed, external iliac artery is exposed. So donor recipient's artery is anastomosed with donor renal vein and artery respectively. So first we start with venous anastomosis, and followed by arterial anastomosis. In case of accessory arteries, we can anastomose differently, and in cadaver, not in this case, but we can anastomose on an aortic patch. So, and finally, this is the ureteric anastomosis, which is done by Lisch-Greger technique and with our DJ stenting, extravesical technique. So in this particular 6 swab, one case was unique in that we have to transplant the kidney upside down. As you can see, the lower pole is up and the upper pole is down. As you can see, the ureter is coming from upside and it is draining in the bladder. So this was to overcome that. As I told, the donor left kidney had multiple accessory arteries, so we took the right kidney. So to accommodate correctly and to increase the length of renal vein, we have turned it upside down. So the vein goes deep and arteries go up, and it is doing very well, sir. So I'll call Dr. Aviral to move forward. Thank you.
So we got all the same patients, all the 6 patients back from the OT. The donors were shifted to surgical ICUs and the patients were received in the kidney transplant ICU. So at this point, so we have already told about the induction regimen. This induction regimen was completed over the first few days. Apart from this, the patients had been started on day -2 on standard immunosuppression. So we continued them on the triple immunosuppression, tacrolimus, mycophenolate mofetil, and oral prednisolone. So 5 of the recipients had an uneventful immediate post-op course. 1 of the recipients, as already discussed, had their paroxysmal supraventricular tachycardia. They all had a steady fall in the creatinine values and a good urine output. And the median creatinine at discharge was 1, and all patients at resistant was removed by 3 weeks. So if you see the trends, the creatinine at discharge are listed here. So that's what we need to see: 1.1, 0.9, 1.3, etc. So this we have follow-up data of these patients up till the 9 months from the time of transplantation. So all the grafts are doing reasonably well. So we have to understand that these are very sensitized patients. So the grafts are doing reasonably well with creatinine values of up to 1.5, and no other major significant complications have occurred till now in the last follow-up. The next follow-up is going to be in the next week or so. So these were our outcomes. We had decent outcomes here. So, but we have to understand the scope of this problem. We have done one such transplants. This is a scenario that is very common throughout the country and throughout the world. So this is just to show the case load. It is chronic kidney disease is projected to be the 5th biggest cause of death by 2040. The incidence is rising as people are surviving more, as we have more diabetics. So in India, we get around 220,000 new CKD patients every year. Unfortunately, our biggest problem is that most of these patients are just diagnosed CKD in stage 5 only, more than half of them. So we have a significant population on dialysis, but the issue is with the quality of dialysis is very patchy, and the access itself to dialysis is not uniform in all the places. So we need to around 3 lakh renal transplants to cover all these patients that we have, those who are going to be eligible for transplants, the stage 5 patients. But the country can only manage to do 10 to 12,000 transplants per year, and more than 80% of the transplants are in the private sector. And around a third of these donors may not be eligible due to AB or HLA incompatibility. So we can go for desensitization, ABO incompatible deceased donor transplants. We can keep them on dialysis, or we can go for kidney paired donation. That was the solution we prefer in this case. So there are many types of kidney donations. So it can be simple two-way exchange. I have a donor, you have a recipient. So we can exchange the kidney. So that is the simplest form of two-way exchange. We can go for a three-way exchange when we have a harder to match donor. We can go for other forms, include the list exchange. These are not in the legal framework in India. We can go for a list exchange. We can go for a domino paired donation, or we can use compatible pairs to help others as well. So about the outcomes. So when we are doing a kidney paired donation, we must understand that any patient who is going for a kidney paired donation, these are patients who have had significant difficulties in getting the transplant done. They may have a long dialysis duration. They may have faced multiple issues during that dialysis period itself. So we should only compare them to those patients who are having similar HLA matches. The HLA matches in always kidney paired donation are going to be less compared. It's always going to be somebody who is not closely related to them. So HLA matches are always going to be 0, 1 or 2, not more than that. So considering all this, it's quite remarkable that kidney paired donation manages to achieve reasonable outcomes. So in India, the kidney paired donation was 1,000, 2,000. Mostly it's single center programs only. We don't have a national registry, so that is the issue. We are not able to do more transplants. So coming to the very significant legal aspects, the Act is from 1994, and that there is a 2014 amendment which is currently covering the kidney paired donation. It is very important to understand only the first degree relative at present can donate in kidney paired donation, and extended family members are not, family members, friends or altruistic donors are not legal for kidney paired donation. We have started kidney paired donation in 2014. We have done around 125. All of them have been single day. We have managed to two 3-way swap transplants and 1 6-way that we discussed right now. So what was remarkable our case is that it was the first 6-way swap transplantation in the whole nation in the private setup, and it is the second overall. So what was also very significant, we managed to do with the resources we had. We have significant resources that we had allocated. We were able to do a simultaneous single center, single day surgery. These were all highly sensitized recipients. It's very unlikely they would have found a donor anywhere else. And they were all medically as well as surgically complex recipients. And we were able to get successful, and the outcomes have been sustained, and in follow-up, the patients are doing well till now. So these were the donors at 1 month after the transplant. These were the recipients, sorry. But 1 month after, as you can see, all were doing well and are doing well till now. We got significant media coverage also for this. So I would like to end the presentation here, and we were saying encourage your patients. there is no barrier to transplant. If we have the resources, if we have the efforts to put into it, almost anybody can get a transplant as long as they have a donor. Thank you.